बिस्मिल्लाहिर्रहमानिर्रहीम कि आपको केस 45 मिनट्स के लिए पेशेंट के साथ टाइम मिलता है। उस दौरान 2 एग्जामिनर आपके सर पर सवार होते हैं जो आपको नोट कर रहे होते हैं कि आपने पेशेंट से क्या बात की। ये प्रेजेंटेशन जो मैं करवा रहा हूं इसमें मैं एज्यूम कर रहा हूं कि आपने पेशेंट को 45 मिनट्स के लिए देखा है। आई एम नॉट एज्यूमिंग कि आप इसको 1.5 घंटे में 2 घंटे में प्रिपेयर करके आए। अगर एग्जाम की प्रैक्टिस करनी है तो बेसिक थीम ये है कि आपको 45 मिनट्स पेशेंट्स के साथ बैठना है और ऐसी सिचुएशन में बैठना है कि somebody should be with you। और फिर आपको 15 मिनट दिए जाते हैं केस को प्रेजेंट करने के लिए और फिर एग्जामिनर 15 मिनट से आधा घंटा आपसे सवाल जवाब करते हैं उस केस से रिलेटेड। ये बेसिक थीम है एग्जाम में केस प्रेजेंट करने की। आई एज्यूम कि जो भी केस प्रेजेंट करेगा आप लोग उसको कोशिश करें कि 45 मिनट्स में उसको पेशेंट के साथ टाइम गुजारें, फिर छोड़ दें और उसके बाद फिर आप उसको समराइज करें। इसमें जो लोग 45 मिनट्स में केस प्रिपेयर नहीं कर पाते कोई हर्ज नहीं है। 45 मिनट्स में सारे साइकाइट्रिक पेशेंट्स को नहीं देखा जा सकता, बहुत सारी चीजें मिस होती हैं। प्रॉब्लम सिर्फ ये है कि आपको जो भी के पेशेंट आप देख रहे हैं उसके साथ जो आपका इंटरेक्शन है 45 मिनट्स में वो अप्रोप्रिएट होना चाहिए। मीन्स के आपको ओपनिंग करनी है, पेशेंट्स की डेमोग्राफिक्स लेनी है, पेशेंट से डिस्कस बात करनी है, हिस्ट्री ऑफ प्रेजेंट इलनेस, फैमिली हिस्ट्री, पर्सनल हिस्ट्री, प्री मॉर्बिड पर्सनैलिटी, मेंटल स्टेट एग्जामिनेशन एंड फिजिकल एग्जामिनेशन। अब ये सारी चीजें 45 मिनट में आपको कवर करनी और अगर आप ये 45 मिनट में कवर कर लेते हैं दैट्स गुड। अगर ये कवर नहीं हो पाता तो एग्जामिनर क्योंकि देख रहा है समटाइम्स पेशेंट डिफिकल्ट होते हैं, म्यूट होते हैं, बात कम कर रहे होते हैं, ग्रॉसली साइकोटिक होते हैं, उस दौरान उनसे सारी इंफॉर्मेशन लेना मुश्किल होता है, डजंट मेक अ डिफरेंस। The idea is that you should be able to handle the patient, get the desired information and then present it appropriately. This is the idea. Examiner ये नहीं देख रहा कि 45 मिनट में ये जितनी चीजें मैंने आपको बताई कि जी आपने हिस्ट्री भी लेनी है, डेमोग्राफिक्स भी लेनी है, पास्ट हिस्ट्री, पर्सनल हिस्ट्री, फैमिली हिस्ट्री, प्री मॉर्बिड पर्सनैलिटी, मेंटल स्टेट और फिजिकल एग्जामिनेशन, लेकिन आपको जो रेलेवेंट एग्जाम से उस पेशेंट से बातचीत करनी है वो 45 मिनट्स चाहिए। 45 मिनट्स के बाद पेशेंट चला जाता है, 15 मिनट में आप फॉर्मुलेशन लिखते हैं, 15 मिनट में आप प्रेजेंट करते हैं और 15 मिनट में एग्जामिनर आपसे उसके बारे में क्वेश्चंस पूछते हैं। अब क्योंकि एग्जामिनर्स आपके सर पे बैठे होते हैं तो उनको नजर आ रहा होता है पेशेंट डिफिकल्ट है, आसान है, उसका डायग्नोसिस पॉसिबल था, कौन से क्यूज आपने मिस किए, और एग्जामिनर उस मामले में आपसे बात भी कर सकता है कि जी आप पेशेंट ये कह रहा था, आपने ये बात इससे मजीद क्लैरिफाई क्यों नहीं की। सो दैट इज इंपॉर्टेंट। आप योर इंटरेक्शन with patient and with examiner should be appropriate and relevant and you will pass. If you have done something that patient was telling you time and again that I'm having difficulty in maintaining the relationships and you don't ask him further questions related to it, you will miss the cue, you will miss the lead, you will miss what is appropriately diagnosis. So examiner can ask you afterwards. So पहले तहसीन प्रेजेंट करेंगे और उसके बाद
I will present also.
And your name is?
सर मेरा है डॉक्टर बख्तावर।
बख्तावर। और बख्तावर आप कहाँ से हो?
सर आई एम फ्रॉम हैदराबाद से।
Good. So okay, let's start with Tehseen. If you people are available, 2 कैंडिडेट्स मैं आज करूंगा और 3 कैंडिडेट्स मैं मंडे को करूंगा। मंडे को इसी टाइम पे हम दोबारा बैठ जाएंगे। आई विल बी हैविंग टाइम, सो मंडे को हम 3 केस मंडे को प्रेजेंट करवा लेंगे। आज हम तहसीन और बख्तावर की देखते हैं प्रेजेंटेशन, और उसके बाद फिर वो 2 चीजें और याद रखिएगा। This is what I am trying to say to you again and again. This is a practice, right? You don't have to panic too much. Keep your nerves controlled. Present preferably a formulation or a summary, because examiner has seen you assessing the patient. So don't worry about too many minor things. गलती हो जाए कोई घबराने की बात नहीं है। ये मकसद मेरा आपको बताने का ये है कि आप अपनी चीजों को करेक्ट कर लें। अगर आप करेक्ट कर लेंगे, यू हैव टाइम, इंशाल्लाह हो जाएगा। एग्जाम है कब?
सर अभी डेट नहीं आई सर।
अभी डेट नहीं आई, सो यू पीपल हैव टाइम। सो एक पेशेंट अभी प्रेजेंट करें, मंडे को बाकी 3 लोग भी प्रेजेंट कर लें, और फिर हम कोशिश करेंगे कि नेक्स्ट वीक में एक दफ़ा फिर प्रेजेंटेशंस आप लोग दोबारा रिपीट कर लें। आप लोगों की अच्छी प्रैक्टिस हो जाएगी, और उसके बाद फिर आप लोग एग्जाम में बेस्ट ऑफ लक। सो तहसीन, योर टाइम स्टार्ट्स नाउ।
Sir, I'm Dr. Tehsin. This is case formulation of Mr. Imran, a 25-year-old middle-caste father of 5 children, farmer from Laya, presented to us by himself through OPD for the management of worsening of his psychiatric illness for the last 2 weeks. Reportedly by patient, he was in his usual state of health 10 years back when his illness started in the background of tense home environment. His illness was abrupt in onset, gradually increased in intensity, and was manifested by repetitive and irresistible intrusive images of sexual in nature during most of the day. He used to neutralize such thoughts temporarily by masturbation 6 to 8 times a day and praying to God to forgive him over such thoughts. Large amount of time was consumed in such activities, followed by low mood, guilty feelings, lack of energy, anhedonia, and disturbed sleep. No death wishes reported during the course of the illness. No sexual offenses reported by the family and by the patient as well. No history suggestive of any preoccupations of holding, body dysmorphophobia, skin excoriation disorder, somatization, or illness anxiety features during the course of the illness. No history suggestive of any elated mood, suspiciousness during this illness. Family consulted with local psychiatric facility 7 years back, and he was prescribed with fluvoxamine initially in low doses, increased to 200 mg in divided doses. With his symptoms after starting with medication, his symptoms followed a remitting and relapsing pattern on account of poor drug adherence. Weight gain was reported during this treatment. Illness has compromised his personal care, interaction with family members, and occupational domains of life. Past history. Past surgical history is significant, as 2 years before his illness, he received road traffic accident and conceived head injury on left frontal area. He remained admitted in neurosurgical department for 2 weeks and discharged without any focal deficit. Family history is significant for psychiatric illness in his mother. She reported to have symptoms of psychosis, and her symptoms are controlled with risperidone 3 mg. And his maternal aunt is also on antidepressant reportedly for his mood symptoms. Personal history is significant for tense home environment. However, it's unremarkable for any childhood repeated chest infections, involuntary movements, neurotic traits, sexual or physical abuse. Once in personal sexual history, he has once physical relationship reported before marriage, but after marriage, no extramarital relationship reported. No history of any sexual paraphilias or homosexuality reported. He's father of 5 children and has constrained relationship with his spouse on account of premature ejaculation. There is history of intake of Hakim medication for aphrodisiac purpose 6 months back, but currently he is not using those medicines. Premorbid personality is significant for anancastic personality traits in the form of perfectionist traits, obeys rules and regulations, and less threshold for tolerance when things get out of order. No history of substance use reported by the family and by the patient. Physical examination is pertinent for old scar mark on over left frontal head area, and his BMI is 29. However, no focal deficit or no any findings on fundoscopy reported in CNS examination particularly. Rest of systemic inquiry is unremarkable. On medicinal examination, he is having compromised self-care, depressed mood, preoccupied with sexual images which are ego-dystonic in nature, depressed mood, guilty feelings, but no ideas of death wishes or sexual offenses, or no ideas of contamination, blasphemy, obsessional doubt, obsessional images, rumination, or any body dysmorphophobia, thought of alienation, possession, reported by the patient during interview. No perceptual abnormality was seen, and his memory registration, short-term and long-term, was intact, with intact abstract reasoning, judgment, and insight into the nature of the illness. Reviewing history and examination on Axis 1 according to IC10, after ruling out organicity, my most provisional diagnosis is obsessive compulsive disorder comorbid with depressive illness without psychotic features and an anancastic personality traits. Points in favor. Criteria for obsession and compulsion met. Criteria for depression met. And person is also having anancastic personality traits. But however, I would like to further explore with the collateral resources. And there's marked impairment in personal, social, and occupational domains of life during the course of his illness. My first differential would be organic change in personality, especially frontal lobe syndrome. Points in favor: head injury, which is on left frontal lobe area, and sexual disinhibition. And points against: abstract reasoning, no focal deficit, no primitive reflexes are seen in my client, which goes against my this organic differential. However, I would like to further rule out in my management plan. On Axis 2, his functionality in personal, occupational, and social domains of life has been compromised, rated as 3/5. On Axis 3, my patient was predisposed to this illness due to anancastic personality traits, family history, positive for psychiatric illness, and precipitated by dense home environment, and his illness maintained on account of poor drug adherence, ongoing stressors, nature of the illness, vulnerable personality. In management, I would like to manage my patient through using multi-agency technique while using BPS model. In biological assessment, I would like to I would like to gather all medical record, all CT scan or MRI which has been done in the past, all medications which has been used during the course of the illness, and also I would like to send all baseline investigation like complete blood count, blood sugar random, liver function test, renal parameter during complete examination, and fundoscopy. If fundoscopy is significant, then I would like to go for neuroimaging to rule out any organicity. I will, in biological management treatment, I would like to get liaison with neurology department to rule out organicity. And in biological treatment, I would like to start with fluvoxamine with adequate protocol, because patient has used this fluvoxamine and has responded to this in future, in past. I would like to inform my client about dietary modification to reduce his weight. In psychological assessment, I would like to apply psychological scale with the help of psychologists like Yale-Brown obsessive compulsive scale to see the severity of obsessions and compulsions. And I would like to apply Beck depression inventory to see the severity of depression. I would like to assess its coping style and unhealthy use of unhealthy defense mechanisms which are being used in OCD, and the expectation of the family and the patient from this treatment, and level of demoralization due to prolonged illness. And I would like to involve his partner to assess about his sexual dysfunction. In psychological management, I would like to psychoeducate the patient and the family regarding the nature of the illness, its course, and its treatment modalities. I would like to start with CBT with exposure response prevention. I would like to apply sex therapy to treat his sexual premature ejaculation. I would like to apply distraction technique while to counter such thoughts. I would like to inform him about healthy stress coping through identification of unhealthy defense mechanisms. And I would like to work on compliance through compliance counseling. In social assessment and treatment, I would like to assess and enhance level of support through family, finance, and friends to engage him in social activities as part of distraction technique. My intermediate goal would be to monitor the response and side effect of medication, to monitor his weight and to reduce his weight through weight reduction strategies. I would like to continue CBT with exposure response prevention. I will work on compliance counseling and also see the results of sex therapy. In long term, I would like to work on relapse prevention. Prognosis. Short-term prognosis seems to be good because patient is admitted in family and patient is also motivated, but long-term prognosis is doubtful, looking into poor prognostic factors like onset at early age, onset of OCD at early age, fluctuating course of OCD, and sexual obsessions, and long history, comorbid depression, and characteristic personality traits. But however, long-term prognosis can be improved by effective pharmacological adherence, psychosocial interventions, and early and regular follow-up. So this is all about this course.
Very good. So you have finished in 13 minutes, which is absolutely okay. And you have covered most of the things. Now, honestly speaking, how much time you spent with the patient?
Sir, I spent almost 1 hour, sir. It was 15
Try
minutes more.
to cut it down, okay?
Yes, sir.
Ghadi dekhe, you have to cut it down to 45 minutes because this is important. Whatever you have said makes sense. It's in a good flow. Continue with it. You haven't missed anything. Examiner will definitely ask you certain questions and I will ask you certain questions as well. But if you cut down the time to 45 minutes, presentation time is 11 minutes precisely, which is very nice. In exam situation, again, with patient 45, presentation 15 minutes and 15 minutes for question answers. So it's good. It's excellent. Just keep it up. Can I ask you questions now?
Yes, sir.
Okay. You said that he was actually prone to develop childhood infection. Let's start from there. What is the correlation of the childhood infections with OCD and what do you call them?
So this is called partner syndrome because streptococcal infections which can predispose to this illness in later life, like OCD.
Perfect. What do you think the head injury was at one of the etiological factors or head injury came after the onset of OCD?
Sir, head injury preceded by this illness, 2 years. These are the lucid interval. Patient conceived head injury before 2 years before this illness, and he remained well, fine, and all his domains of life remained good, and for 2 years. Then, after facing tense home environment, he personally experienced this phenomena of OCD.
So do you have any idea that OCD is related to which area of the brain?
Orbitofrontal cortex, sir.
Okay.
Thalamocorticostriatal loop से इसमें dysfunctional हो जाती है.
Orbitofrontal cortex is enough. Don't go into that detail, otherwise you'll be stuck. So stay to one thing. Orbitofrontal cortex. Okay. If the patients sustain some kind of head injury, and the head injury later on gives some scarring of the tissue around the region of the orbitofrontal cortex, and he developed the symptoms after a couple of years after sustaining the head injury, would you change your prognosis?
Yes, of course, sir.
So what will be your
it may lead into poor prognosis.
It leads to poor prognosis because of structural brain damage, right?
Yes, sir.
Okay. You have mentioned the BMI of 29. Who calculated this?
Sir, I myself I measured his weight divided in height.
इतना टाइम था कि तुमने वेट भी कर
Weight
लिया
in kg. Yes, sir. I consumed 1 hour.
एग्जाम में शायद ये पॉसिबल ना हो, ठीक है? वेट मशीन पता नहीं हो ना हो, वो हॉल में पड़ी हुई होगी तो पता नहीं मिलेगी नहीं मिलेगी. सो थोड़ा सा ऐसी चीजों को अवॉइड करो जो एग्जाम में आपको थोड़ा सा कंफ्यूज कर सकती हैं. सो विच इज आइडियली स्पीकिंग, यस, यू आर एब्सोल्युटली राइट. I will agree with you that you should calculate the BMI because it is an important thing to be mentioned. But in exam situation, a little bit complication. So just try to ignore it. Okay. Then you said that anencaustic personality disorder. What do you mean by that?
Sir, pervasive symptoms of such personality disorder are person becomes a perfectionist, persons rigidly obeys some rules and regulations, and he is not able to he is eager to work on his skills and work, and not satisfied with the other people work, and always eager to improve his work on daily basis, and have some stress prone.
This is okay. This is okay. Don't go beyond that. Okay. Last question. Give me 6 6 medications that can help people in OCD and their approximate dose range.
Okay. Sir, starting with SSRI like fluoxetine, and in 40 to 60 mg in divided doses, initially starting from the low dose. Number 2, sir, or we can start with fluvoxamine, or we can start with sertraline. These are 3 choices among SSRI. If the person doesn't respond to these, then we can add clomipramine, that is, and if the person doesn't respond with while adding to an antidepressant, then we can add with some low dose of antipsychotic like risperidone or aripiprazole. And sir, these are medications, and there are some new medications as well, like we can give him topiramate, almost 150 mg, to cut down his compulsivity. So these are some such medications which can be used, sir.
Evidence कम है, इसलिए थोड़ा सा केयरफुल, फिर उस पर बात आगे चली जाएगी. 6 पूछी हैं तो 6 में से आपने 3 SSRIs बताई, 2 एंटीसाइकोटिक बताई, तीसरी फिर आप क्लोमिप्रामीन ट्राइसाइक्लिक एंटीडिप्रेसेंट बता दी. 6 काफी, 7वीं को मत छेड़ो. So fluoxetine, fluvoxamine, sertraline, clomipramine, aripiprazole and risperidone as an augmentation strategy. 6 मैंने पूछी थी, 6 काफी. टोपिरामेट को छेड़ोगे, अगले सवाल उस पे शुरू हो जाएंगे, एक बखेड़ा खड़ा हो जाएगा. Don't scratch where it doesn't itch. 7वीं नहीं बोलनी. ओके, ये एग्जाम में थोड़ा सा केयरफुल रहना. किसी ऐसी तरफ जाओगे जहां पे एविडेंस कम होगा तो एग्जामिनर उस पे सवाल ज्यादा पूछ सकता है. सो यू हैव टू बी केयरफुल अबाउट इट. आपसे 6 बार हुई थी, 6 बताओ. डोज आप रेंज आपको सारी साथ साथ बतानी है. फ्लुओक्सेटिन 20 to 80 milligrams per day depending upon the response. Fluoxamine ranging from 50 milligrams up to 300 milligrams per day. Same goes for sertraline, 50 milligrams to 300. We may go up to 450, but usually the evidence is lacking, but there are some reports that patient can respond to that. So that is the way you should be going for it, which is fine. I am absolutely okay with it. The only one concern that I have for you is that you were using ICD-10, right? और अभी मैंने जैसे रिसेंटली ICD-11 पढ़ाया था. ICD-11 को आए हुए अब 10 महीने हो गए हैं, ऑफिशियली लॉन्च हो गई है. सो ICD-10 को कोट करना थोड़ा सा बैकग्राउंड में आपको डिसएडवांटेज दे सकता है. एवरीथिंग वाज एब्सोल्युटली ओके एक्सेप्ट व्हेन यू सेड ICD-10. तो मैं थोड़ा सा पीछे हो गया. बाकी अदरवाइज it was fine. You responded to the questions, you were prepared well, you presented well, all time given in time frame, so it was fine. Don't quote ICD-10. If possible, quote ICD-11. That is the best way to move forward. Examiners जो आपको बहुत अच्छा लेके जा रहे हैं ICD-10 पे, थोड़ा सा वो अगर कोई मेरे जैसा सरफिरा एग्जामिनर हुआ तो वो आपको ड्रॉबैक में ले जाएगा. वो मैं नहीं चाहता. आप अच्छा जा रहे हो तो ICD-11 को इनकॉर्पोरेट कर लो. और ICD-11 में पर्सनालिटी डिसऑर्डर्स में एनएनकास्टिक का रोल नहीं है. सो वो चीज़ ख़त्म हो जाती है, उस पर डिस्कशन ख़त्म हो जाती है और वो उस पर मज़ीद फॉरवर्ड आप नहीं जाते. ICD-11 में OCD जो है वो OCRDs कहलाते हैं, ऑब्सेसिव कंपल्सिव रिकरेंट डिसऑर्डर्स. और उसमें आपने बाकी सारी चीज़ें क्योंकि रूल आउट कर दी, इम्पल्स कंट्रोल नहीं है, पैराफिलियास नहीं है, which is fine. So we are restricted now to OCD, which is absolutely okay. But ideally speaking, don't quote ICD-10 now. Use ICD-11. सारी प्रेजेंटेशन अच्छी थी, क्वेश्चन के रिस्पॉन्सेज अच्छे थे, जस्टिफाइड था. 3 चीजें जो मैं कह रहा हूं. एक, टाइम फ्रेम. घड़ी देख के 45 मिनट पेशेंट के साथ, उससे ज्यादा मत लगाएं. दूसरा, रीसेंट क्लासिफिकेशन सिस्टम ICD-11 को यूज करें. और तीसरा, जब एग्जामिनर ने आपसे 6 दवाई पूछी, 7वीं मत बोलना, ठीक है? 6 पे रुक जाना. अगर एग्जामिनर ने 4 पूछी हैं तो जो टॉप प्रायोरिटी में पहली 4 का एविडेंस है वो बोलो, बाकी मजीद अपनी तरफ से ऐड मत करना. यूजुअली अगेन, अगर मैं एग्जामिनर हूं और मुझे कोई 7वीं बोलेगा तो जाहिर है मैं पहली चीज ये होगी कि छठो पिरामिड का क्या एविडेंस है, क्यों आप ये बोली, क्या ये किस क्लासिफिकेशन सिस्टम में वो जो प्रिस्क्राइबिंग गाइडलाइंस हैं उसमें इसको रिकमेंड किया गया है. सो सवाल कॉम्प्लिकेट होते जाएंगे. सो उसको थोड़ा सा बैकग्राउंड में रखो. इट्स अ गुड थिंग दैट यू नो इट, बट इट्स अ डिसएडवांटेज व्हेन यू कोट इट अदरवाइज. गॉट इट? क्यों तहसीन? इज ही हियर? चले गए? खत्म तो नहीं हो गया? ओके.
Is here, sir.
Okay.
He's here.
So I hope that this was a nice feedback. एक केस और प्रेजेंट कर लें. मे बी अगर मंडे को हमारे पास टाइम हो तो एक और प्रेजेंट कर लो तो आई थिंक दैट विल बी ओके. बट उसको टाइम कंस्ट्रेंट्स के साथ प्रेजेंट करना ताकि आपको अपनी डेफिशिएंसीज का अंदाजा हो और आप उसके साथ फॉरवर्ड करें. नईम साहब को मेरा सलाम कहना बहुत बहुत, उनके लिए बहुत सारी दुआएं और बेस्ट ऑफ लक इन एग्जाम. ठीक है तहसीन?
थैंक यू वेरी मच सर.
यू आर वेलकम.
थैंक यू.
मुझे अब दूसरा कौन प्रेजेंट कर रहा है? बख्तावर.
Sir, Dr. Tuba wants to present also. तो ये अब आप देख लें.
अच्छा, इस बख्तावर है?
यस सर. अस्सलाम वालेकुम. डॉक्टर तहसीन की वो सुन के तो आई फील.
You feel what?
Okay. you know, I need
बेटा
to
आवाज
recognize
कम
where
आई,
I'll do.
जोर से बोलो, घबराने की कोई जरूरत नहीं. You feel
Hello,
that
sir?
you don't want to do it now. You need more
No,
time.
I feel like Dr. Tahsin की सुन के कि I need, you know, further improvement और इस तरह से. तो फिर I was
बेटा
like कि
देखो,
अगर Dr.
एक
Tuba wants
चीज,
to do तो well and good.
चलो तुबा के साथ प्रेजेंट कर लेते हैं. मैं पूछ लेता हूँ तुबा से. दो चीजें याद रखना.
Yes, sir.
एक तो ये कि हेजिटेंट मत हो. The more you will present, the better it is. और खास तौर पे स्ट्रेंजर्स के सामने प्रेजेंट करना कॉन्फिडेंटली मैटर्स मोर. मैंने जैसे पहले शुरू में कहा था, ये मैटर नहीं करता कि आपने सारी चीजें कवर की हैं या नहीं की हैं. मैटर ये करता है कि 45 मिनट्स जब आप पेशेंट के साथ थे, आपने कोई क्यू मिस नहीं किया. मैटर ये करता है कि आपने कोशिश की कि चीजें कवर अप हो जाएं. मैटर ये करता है कि आपके डिफरेंशियल और फॉर्मुलेशन में जब आप प्रेजेंट कर रहे हैं तो वो 15 मिनट से पहले खत्म हो जाए. मैटर ये करता है कि एग्जामिनर अगर आपसे कोई सवाल पूछता है तो उसको आप जस्टिफाइबली एड्रेस कर देते हैं. ये चीजें ज्यादा मैटर करती हैं. साइकियाट्री में कोई मरीज, इवन अब तक मेरे साथ भी ये होता है कि पेशेंट आया, मैंने आधा पौना घंटा भी उसको देखा, फिर भी कुछ पेशेंट का डायग्नोसिस, कॉन्क्रीट डायग्नोसिस मैं एस्टैब्लिश नहीं कर सका. ये साइकियाट्री में होता है. लेकिन कॉन्क्रीट डायग्नोसिस देना जरूरी नहीं है. हाँ, एक अप्रोप्रिएट डिफरेंशियल डायग्नोसिस देके ऐसा मैनेजमेंट स्ट्रैटेजी प्लान बना के देना फॉर्मुलेशन में कि उस एग्जामिनर को लगे कि आप फ्लो में चल रहे हैं, आप सेफ साइकियाट्रिस्ट हैं, आपने कोई ब्लंडर नहीं किया, आपने हर चीज को जस्टिफाइबली डिफेंड किया. दैट इज मोर इंपॉर्टेंट देन how you present. Yes, it creates a good impression if you are presenting well. Prepare well. Monday को present करना. ठीक है बख्तावर?
Thank you, sir. Okay, sure, sir.
अब आपके पास 2 दिन हैं, अच्छी तरह तैयारी करो. तैयार करके 45 मिनट्स पेशेंट को देख के, बेशक 45 मिनट्स पेशेंट को देख के बाद में 20 मिनट 25 मिनट लगा लेना उसको फॉर्मुलेट करने के लिए, लेकिन उसको कर लो. एक दफा उसको अच्छा फॉर्मुलेट कर लोगे तो सारे डायग्नोसिस में वो चीजें हेल्प करेंगी. क्योंकि फॉर्मुलेशन 6 मेजर साइकियाट्रिक डिसऑर्डर्स ने जो एग्जाम सिचुएशन में आपको मिल सकते हैं, जिनकी पॉसिबिलिटी सबसे ज्यादा है. बहुत कम चांसेस होता है कि आपको कोई अनयूजुअल डिसऑर्डर मिले. लाइक कॉमनली जो आते हैं, जो अस्पतालों से मरीज एग्जाम सेंटर में लेकर आए जाते हैं या सिमुलेटेड एग्जामिनर्स बिठाए जाते हैं, उसमें ज्यादातर स्किज़ोफ्रेनिया, एमडीडी, ओसीडी, बाइपोलर, ठीक है, ये कॉमन है. डिसोसिएटिव और कैटाटोनिया में भी, न्यूरोलॉजिकल पेशेंट में भी. उसके बाद बाकी सारे डिसऑर्डर्स जो है ना, सब्सटेंस अब्यूज, यस, बाकी सारे डिसऑर्डर्स जो है ना वो रिलेटिवली कम होते हैं. वो बदकिस्मती कि आपको कोई ऐसा पेशेंट मिल जाए जिसको पीटीएसडी हो, लेकिन पीटीएसडी वाला पेशेंट आमतौर पे बड़ा कम्युनिकेटिव होता है, सो आप वो डायग्नोसिस मिस कर नहीं सकते. या अगर सपोजली किसी पेशेंट को मॉर्बिड जेलसी है तो वो मिस होना उसका रिलेटिवली मुश्किल है. हिस्ट्री भी शॉर्ट होगी, ब्रीफ होगी, सिम्टम्स भी आपको पता चल जाएंगे. सो घबराना नहीं. 40 मिनट्स में प्रिपेयर करके मंडे को मुझे प्रेजेंट करो. ठीक है?
Yes, sir.
गुड. सो तुबा, would you like to present?
Yes, sir. Am I audible to you?
Absolutely. Go ahead.
The patient assigned to me is 20 years old male, Mr. M, single, educated up to intermediate, working in Pakistan Coast Guard as a Sipahi since almost 1 year. Referred by his department and psychiatric facility for assessment purpose and admitted as inpatient for 2 weeks. Complains of hearing voices of jinns and belief that he is under the control of jinns for 1 year. According to patient, he was in his usual state of health 1 year back when he joined Pakistan Coast Guard as a Sipahi. And according to the nature of his job, he also handles weapons, including rifle. Within a month of within a month of joining his job, he started hearing voices of jinns who used to pass derogatory remarks on him and were threatening to kill him. As a revenge, as they said that patient's verbatim was कि तुमने हमारे बच्चे मार दिए हैं. Voices का content है. Patient explained that he might have passed from such some bad place. Uh, Patient is extremely fearful of these voices. He also sees jinns who appear as air without any form shape. He also believes that jinns are controlling him. His body is under the influence of jinns. He feels his body is heavy. Patient reported that jinns also pushed him forward once he was making wudu at his job place, and once they tried to pull his legs when he was climbing to his duty position. Few days back, jinns also tried to strangle his neck. He's becoming socially withdrawn in past 1 year. His sleep remains disturbed. He denied thought insertion, withdrawal, broadcast, delusional perception. No associated depressive and manic symptoms reported. No suicidal and homicidal thoughts. No acts of violence reported. He consulted faith healers for above mentioned reasons, taweez and holy water, on which his symptoms were improved but then relapsed again. No past psychiatric history, no prior psychiatric consultation. There is history of typhoid and dengue prior to the onset of psychiatric illness, almost 1 year back. No history of head injury and fits. No known family history of psychiatric illness. Parents alive. Father has cardiac illness. 4 brothers and 3 sisters. Birth history and milestones are unremarkable. He was average student in studies, and he used to work at fridge and AC shop prior to current job. Denied use of any psychoactive substance. Premorbidly, patient's predominant mood remains euthymic. He has many friends, but superficial friendships. He shares his worries with parents. On MSc, young male of tall height, thick build, sitting comfortably on chair, moderately kempt, slightly grown beard, making and maintaining eye contact. Rapport was established. Speech was relevant, coherent, uh, over-inclusive, normal volume and tone. Mood was anxious, subjectively and objective. Thought process, no formal thought disorder. In content, he was preoccupied with thoughts of jinns, delusion of control, perception, auditory and tactile hallucinations. In cognition, patient's orientation, judgment, attention concentration, register recall were intact. Insight is absent. Patient considered it to be a spiritual illness. General physical examination, besides pallor and hence it was unremarkable. Why differential diagnosis include schizophrenia and fictitious disorder.
Acute what?
Fictitious disorder.
Fictitious disorder, fine, but what was the first one?
Schizophrenia.
Okay, don't say acute. Schizophrenia. Okay, one was the schizophrenia and number two is the fictitious disorder. And do you consider anything else?
Sir, I have also kept on third as organic brain syndrome, mental and behavioral disorder secondary to.
Okay, go ahead. Continue.
Okay. In my management plan and assessment, I would like to go for CUC LFTs, and I would like to perform psychometric assessment scales, PPRS and PENS. As well as I would like to take collateral account and observation by staff and on-call doctors during admission. In treatment, I would like to start him with antipsychotics, preferably atypicals.
Continue. Sorry, Tuba. I stopped hearing you. Can anybody else hear?
No, sir. We can't.
क्यों बेटा? Are you still there, Tuba? Can you hear me?
Hello.
I can hear you now. So you were telling me some about management strategy and medication. So go ahead.
Sir, I have completed whatever I prepared. Like you
Okay.
can ask questions.
Okay. आप कहाँ से कर रहे हो पोस्ट ग्रेजुएशन?
Sir, I have completed residency from Civil Hospital Karachi.
Okay, good. The good thing is that your flow is very nice, and I believe that your English is very nice as well. So that is an advantage to you when you are presenting the cases. Uh, Again, as the scene presented, you have to complete the whole of it. You were doing absolutely fine till the time your history finished. I believe that probably you never was expecting to add the other things like etiological factors, precipitation, predisposing, and maintaining factors, plus other issues. The one thing that you missed, which I
Yes.
would definitely like to hear, is substance abuse. He's a 20-year-old young man with a 1 year history of psychosis. Is there any abuse of any drugs? Although you mentioned that family said that there is no abuse, but I would still like to rule it out. And as far as the medication is concerned, you said that you would like to start with the atypical neuroleptics. Fine. Be very specific. I would like to start with the atypical neuroleptics like weight uska dekhte hue, maybe risperidone from 2 to 6 milligrams per day, gradually building it up, slowly starting from 2 milligrams and maybe increasing it to 6 milligrams per day. And also definitely comment on psychological interventions. What would you like to do? And also comment on the prognosis as well. He's a young man. You never mentioned any positive family history. The effect was okay. There were no, again, relatively, you said anxious. This means that probably he is still not having blunting or flattening of effect. It's a short history as well. So hopefully the prognosis and outcome is good. So that is the way. You were doing absolutely okay till the time the last component. I don't know what happened. You got anxious or sometimes, well, control your anxiety. Be fluent. जितना अच्छा चल रहे हो उतना ही चलते रहो. No problems at all. Honestly, I don't think so that you will have any issues. The way you started off, I thought, okay, fine. So she's okay as well. But abruptly, आखिर में आके, I don't know, anxious हो गए, थोड़े से cautious हो गए शायद, तो वो थोड़ा uneasy हो गए. उसको overcome करो, you'll be fine. Would you like to present again?
Yes, sir. Yes. Yes, I
Done.
would like.
मंडे को दोबारा प्रेजेंट करो और अब की दफा पूरी फॉर्मुलेशन प्रेजेंट करो. डोंट हेजिटेट. डरना किस बात से? अगेन कोई डरने वाली बात नहीं है. वर्स कम वर्स की है, एग्जामिनर फेल कर देंगे, कर दें. You see, exam is a very tricky thing. It's basically that is your day. Sometimes very good candidates also fail. This never means that they are bad candidates. It means that unfortunately something happened that day which never turned out to be in your favor. So sometimes the patient is difficult, sometimes the patients are aggressive, you are not able to do the mental state examination and examine the patient. So it could be anything. It is multifactorial. There is not only one factor. This is the reason why I always say examiners like to see how you handle the patient, how you are expecting the outcome, what exactly the strategies you are planning to implement on the patient. You are all have done 4 years of psychiatry as far as your postgraduate training. And this much you know that this is schizophrenia, this is depression, this is bipolar, this is conversion. I never had doubts that the candidates are not able to see that, But the only problem is that when you are expressing yourself. So this is the skill that is checked in the exam if the psychiatrist is able to express. You are good in English, you are good in the flow, you know the way how you to talk. Don't underestimate yourself. Got it?
Right. Yes, sir.
फिर अब
Yes.
मंडे को करना है प्रेजेंट.
Okay, sir. Yes, I would like to present again.
और अब की दफा रुकना नहीं है. ओके?
Okay. Okay.
तो मंडे को बख्तावर करेंगी, तूबा करेंगी, तहसीन भी एक पेशेंट और करेगा, और 2 कैंडिडेट्स और कौन से थे जिन्होंने करना है? आर दे हियर?
सर एक डॉक्टर एलिया ने करना था और एक डॉक्टर आयशा ने. एक डॉक्टर आयशा थी. उन
5 को आप 5 पेशेंट के साथ घड़ी देख के 45 मिनट्स गुजारना. बस 45 मिनट से 1 मिनट ऊपर ना होने देना. और जितनी इंफॉर्मेशन आपको 45 मिनट्स में मिले, उसके बाद उसको अच्छी तरह बैठ के फॉर्मुलेशन तैयार करना. और फॉर्मुलेशन जो तैयार करना, उसको कॉम्प्रिहेंसिवली बेशक आधा घंटा लगा के प्रिपेयर करना. वो एक दफा अच्छी फॉर्मुलेशन प्रिपेयर हो गई, फिर उसको प्रेजेंट करो, फिर मैं बताता हूं कि क्या करना है. इज इट फाइन बख्तावर?
वेरी वेल. ठीक है, डन.
ठीक है, गुड, शाबाश. कोई डरने की जरूरत नहीं है. यू पीपल हैव टाइम, यू पीपल नो व्हाट आर द थिंग्स. अगर फॉर्मुलेशन में कोई चीज मिस हो तो मेरी जो यूट्यूब में चैनल में प्रेजेंटेशंस पड़ी हैं, उनमें एक पेशेंट कुछ कैंडिडेट्स ने फॉर्मुलेशन प्रेजेंट की हुई है, और मैंने भी बताया हुआ है कि फॉर्मुलेशन कैसे बोलनी है. उसको प्रिपेयर करो और फिर मुझे बताओ. एक गेस्ट यूजर का हाथ खड़ा हुआ है. हु वांट्स टू आस्क अ क्वेश्चन? Go ahead.
Assalamualaikum, sir. My name is Dr. Binish. My name is Dr. Binish. I am a third year resident in Civil Hospital, Karachi. Sir, I want to ask a question, if you allow.
Sure.
My question is about ये जो डॉक्टर तहसीन ने केस प्रेजेंट किया था, इसमें उन्होंने जो चीजें बताई थी, उसमें XS1, XS2, XS3 इस को भी उन्होंने कैटेगराइज करके बताया था. So I want to ask कि ये सारी कैटेगरीज मैं कहाँ से पढूं, ये मुझे कहाँ पे मिलेंगी? Because मैंने अभी तक अपनी इसमें नॉलेज में ये वाली चीज नहीं देखी.
देखो, बात फिर हुई है ICD-11. मैंने ICD-11 की जो प्रेजेंटेशंस की हैं उसको सुन लें. अब आप थर्ड ईयर में हो, ICD-11 को ऑप्ट करो, ICD-11 को प्रिपेयर करो,